So now let's get ready uh, to ignite the discussion. Our next section is a debate on sentinel lymph node biopsy. So get ready for the lively discussions and deeper understandings of sentinel lymph node biopsy. I would like to welcome Dr. Richa Vaish. She is a professor in the Department of Head and Neck Surgical Oncology, TMH Mumbai, to speak for sentinel lymph node biopsy.
Good evening, everyone. And I would really like to thank Aseem and Sunena for organizing this workshop and giving me the opportunity to demonstrate and to talk on the topic which is so close to my heart. So the debate today is sentinel node biopsy for oral cancer, and I'll be speaking for the notion, although my trial is against sentinel node biopsy, but it's a disclosure. So let's first define the problem statement. We know from this landmark presentation that elective neck dissection is a must in this set of patients. It offers an overall survival benefit of 12.5%, reduces the risk of death by 36%. It improves disease-free survival by 23.6% and reduces the risk of recurrence by 55%. So every 8 neck dissections that we are performing, we are preventing 1 death. And with every 4 neck dissection, it is a prevention of 1 recurrence. The same findings were also reinforced by the SEN trial, Ian Hutchison, UK, and we see a similar overall survival benefit of 12% and disease-free survival benefit of about 18%. And this led to the incorporation of elective neck dissection in the standard guidelines, and it is a standard of care today. So why are we even looking out for the alternative? Because the trials that have established this procedure as the standard also brought out some important points. So about 55 to 70% of the patients are actually node negative and are being overtreated by this approach. So we are not offering any survival benefit to them, but we are giving them the morbidity of the neck dissection. So as we can see, grade 1 and grade 2 morbidity is seen in about 58% of the patients, and it can also be grade 3 and grade 4 in 20% of the patients. And this is not only the nerve damage. There can be problems with swallowing, problems with vocal cord, swollen glands, problem with taste, hearing, and wound healing, and so forth. So there is a need to look out for the alternative. And when we're looking out for the alternative modality, what do we want? We want a modality of the technique that can identify the true node negative cases so that we can spare the unnecessary neck dissection in those cases. It should be oncologically safe. It should reduce the morbidity. It should improve the quality of life, should be cost effective, and it should be acceptable by the subjects to whom we are offering. And let's see if really sentinel lymph node ticks all these boxes. So coming on to the first point, to identify the true node negative patients. The diagnostic accuracy of sentinel node biopsy in oral cancer in head and neck cancer has been long known. We can see from 2005 onwards, for the last 2 decades, that the negative predictive value of the sentinel lymph node biopsy is upwards of 90 and 95%. So we can really rely on this to spare the neck dissection, but it's only the diagnostic accuracy, and we were all still waiting for the level 1 evidence to establish the oncologic safety. Towards the end of 2020 and in the beginning of 21, 2 trials, finally, this was a head-on comparison between the gold standard elective neck dissection and the sentinel node biopsy that we were able to establish the oncologic safety of this procedure. The first is a French trial by Renaud Guerrel, and this was a sentinel trial, multicentric, randomized, open-label, prospective equivalent study. The endpoint for this was 2 years neck node recurrence-free survival, and this trial analyzed 279 patients. And we can see here completely overlapping curve for 2 years and 5 years neck node recurrence-free survival. So this trial showed us that the 2 procedures are equivalent in terms of the oncologic outcome. Another trial which corroborated the finding was a Japanese trial by Hasikawa. This was also the multicentric randomized control trial across 16 Japanese centers. And the primary endpoint for this trial was 3 years overall survival. And again, at the median follow-up of 3.1 years, 271 patients analyzed, we see completely overlapping curve for the overall survival and very similar outcomes in terms of the disease-free survival. We see slightly numerical benefit with the sentinel node, but of course, the difference was not significant, and both these trials together established the oncologic safety. These trials were heavily criticized for wide non-inferiority margin of 10 and 12% respectively. And therefore, from Tata Hospital, Dr. Gupta published the meta-analysis combining the 2 trials. So number now is 550. And again, we see completely overlapping curves for the overall survival. So if we think about the power estimation and the non-inferiority margin, then with this such a number, it would be around 6 to 7%, which I think now is within the acceptable limits. So no doubt about the oncologic safety of the sentinel node biopsy in this scenario. It also offered the added advantage. So we know that a lateralized lesion may have a bizarre representation of the contralateral metastasis in about less than 5% of the patient, but we are surely to miss these patients with the elective neck dissection approach. So with sentinel node biopsy arm, we can identify these patients and treat them appropriately. As we can see from this paper, higher number of contralateral regional recurrences with elective neck dissection compared to the sentinel node biopsy arm in 816 lateralized lesions. Now coming on to the thing, whether it is reducing the morbidity or improving the functional outcome. So again, we go back to the landmark trials and we see from the French trial that the median hospital stay is shorter with the sentinel node arm. When it comes to the functional outcome assessment, we can see with the radar plot on the right side that when we compare the symptoms, we have a significant worse symptoms with the elective neck dissection compared to the sentinel node biopsy arm. We notice that as the time passes, the curve started to overlap. So that means some improvement in the elective neck dissection arm, but that is up to the end of 12 to 24 months. Also significantly higher number of physiotherapy prescription being issued in the neck dissection arm, again pointing to a strong need for the rehabilitation because of the crippling because of the neck dissection. This is our data from the Japanese trial. Again, we see in terms of the neck dissection quality of life questionnaire, symptoms like constriction, pain, numbness, shoulder drop, overhead abduction appearance, everything is inferior when it comes to the elective neck dissection compared to the sentinel node arm. And overhead abduction, again, we have poorer scores in the neck dissection group compared to the sentinel node arm. So clearly, sentinel node is better in terms of the functional outcome compared to the neck dissection arm. There were adverse events in both the arms. Numerically slightly more in the elective neck dissection arm, but it was not statistically significant. Now coming on to the points of improved quality of life and whether this procedure is really cost effective. So do we have some data there? Yes, we do have some data there too. So in health utility, now this is a study published in 2016. They compared the health utilities in patients with the T1, T2 oral squamous cell carcinoma who were treated by watchful waiting, the sentinel node biopsy, elective supraomohyoid neck dissection, and therapeutic modified radical neck dissection. Simple study, and they just use a questionnaire of EuroQOL 5D3L, which is easily available. And just look at the outcomes. So 181, 62% of the patients actually responded. And we see that more invasive the procedure, the results are lower in terms of the health utility. So we see that sentinel node biopsy has a highest health utility. We see when it comes to the mean shoulder disability score, of course, the watchful waiting is the best, but I think a little we can accept it's a trade-off between the shoulder dysfunction and the better outcome in terms of survival. So that trade-off is acceptable, and that's why probably the shoulder dysfunction with a slightly higher score is also acceptable in the sentinel node biopsy. Another paper which looked at the cost effectiveness, a Markov decision analytical model, and they compared even other approaches to treat these patients, not only the elective neck dissection and sentinel node. So elective neck dissection, waiting watch approach, gene expression profiling, and then deciding the management of the neck, sentinel lymph node procedure, then deciding the management of the neck, and clubbing the two, and then deciding the management of the neck. And on the base case analysis, it showed the sentinel procedure followed by the neck dissection or waiting watch was the most effective and most cost-effective way to go ahead. So we have the box that is ticked there too. Now comes the last point. Is it really acceptable to the patient? Do they get worried that we are not taking out the entire neck? So is there a possibility of the disease coming back? And the negative thoughts. So let's see what's there. So this is a semi-structured interview with a median follow-up of 4.5 months. Again, 88% of the patient responded. It had the cohort which had node positive, sentinel node positive, and sentinel node negative patients. And overall, patients, nearly 86% preferred the sentinel node-based strategy compared to the elective neck dissection strategy. There was no significant difference in the sentinel node biopsy negative and positive patients for investigation of the emotional burden by intrusive thoughts and fear of tumor presence. So it's acceptable to the subjects as well. So I think this technique has ticked all the boxes, and that's why rightfully it has been now incorporated in the NCCN guideline as a very, very viable alternative to the elective neck dissection. Having said that, I would also emphasize that, of course, this has some limitations, like it needs the infrastructure. It's a two-stage procedure in about 10% of the patient. As Dr. Neha rightly emphasized, that it's too much of a work. So it's less for us, it's much more for them. So a very labor-intensive pathology protocol. And therefore, it has a limited applicability when it comes to resource constraint and a high volume center. So can we do something about it? Yes, there are alternatives that are being explored. So this is one approach which is being explored in Europe, and they have talked about centralized pathology services. When we talk about it's going to take a lot of time with the centralized pathology services, the mean and mode laboratory turnaround time was only 5 and 4 working days. So this will give us adequate time to go back in and complete the NET, even if it's a second stage procedure, and complete the radiotherapy well in time. Again, of course, Dr. Vani, in such detail and so beautifully, she told us about the whole course of sentinel node biopsy in the breast cancer. So can we pick up something from there? Yeah, we can. So here it is, the approach, as Dr. Neha also emphasized, AI-based approach, and there can be models to identify the macro metastasis and IDCs. Of course, the biology is different. We will have to develop our own algorithms, validate it, but it's a very viable approach, which will be helpful to the pathology significantly. So we many a times say how long, now we have the level 1 evidence. Today, is it the standard of care? Is every center doing it? And there have been numerous surveys, and I'm quite sure that my opponent may bring out that data that very few centers are actually following it. So I'd just like to emphasize that it takes several years and decades, even if you have done extensive research. And the classic example, if you look in the breast and the melanoma, it took 40 years from the identification of the technique to really it became the standard of care, where we believe that it's very, very helpful. And whenever a new technique is implemented, this is the curve beautifully described by Wilson. So there'll be innovators and early adopters. So this is a curve we see, and once about 10 to 20% of the population accepts it, then of course we have a quick rise, a quick peak, and then there's a plateau and there are laggards. So if I would request my worthy opponent, even if we are not innovators, at least we can be early adopters and not the laggards. So when everyone else has accepted it, then we are going to do it. So let's be the at least early adopters, if not the innovators. So with this, I conclude that sentinel node biopsy is an oncologically safe procedure. It limits the morbidity and shortens the hospital stay. It improves the quality of life of the patient. It is a cost-effective procedure. It has some limitation, but for that, we don't have to throw the procedure in the long grass. Of course, we should direct the efforts to identify these limitations and overcome these. And the sentinel node biopsy for oral cancer is definitely the way ahead. So thank you so much.
Thank you, ma'am. Now I would like to request Dr. Aseem Mishra. He's a professor and head in the Department of Head and Neck Surgical Oncology, MPMMCC Varanasi, to give his opinion, or I may say differing opinion, on sentinel lymph node biopsy.
So good evening, everyone. And Dr. Richa had very well presented, talking about laggards, talking about innovating, and talking so much about sentinel node biopsies usage. And I stand hosting a conference of sentinel node biopsy to prove that I'm not against science. And innovation is interesting. Innovation is very exciting. But in that excitement, we must not replace the evidence of the standard of care. And therefore, the burden of proof that lies on the people who are advocating the change and not who are actually safeguarding the standard of care. So what does sentinel node biopsy does not tell us? We have been doing procedures in the last 2 days and finding out that we do not understand the biology of the primary disease and how the disease is going to metastasize. Sentinel node biopsy, for those who may not understand, we have to inject a dye, we have to pick up the radio tracer, and we get that this is the node which might be draining. But we do not understand the biology, whether that tumor is throwing the metastasis or not. We understand that if we remove that sentinel node biopsy, we are pretty sure that we may not have the positive or a negative node. So we need a pathologist. So as Dr. Neha pointed out, that this becomes a frozen heavy or a histopath heavy exercise. And then what is the extent of the involvement of those nodes? So to begin with, we know we are going for a cumbersome procedure, which is labor-intensive pathology protocol, limited applicability in resource constraints and high volume centers, and I will come to that why. We need a significant amount of infrastructure that our institutes, everybody else's institutes, they have to think about building that infrastructure. And I am not against science-minded. And then 10% of them are going to require, and in our high volume center, that 10% itself is going to be at least 200 to 300 cases. So that's one case per day. And when this article was published, and this was published after a lot of labor intensive work, and we did not stumbled upon the findings of this trial, which very clearly proved that elective neck dissection is the standard of care for all clinically N0 patients. Now, just because in this small group, there was a hypothesis generating idea that if the tumor is less than 3 millimeters, there might be a possibility that we may observe. And then simultaneously, there was a research being conducted on sentinel node biopsy. So everybody started focusing on that we can select certain patients. And I do agree that, yes, we can select certain patients for sentinel node biopsy. But we have to be very, very selective in making those selections. And the reason this trial was done in our country. And in our country, the average delay is 7 months for presentation. And much of it is also the physician-related delay, as compared to the developed countries of just 21 to 3 months. So all patients that present to us, we will have to do a biopsy, we will have to conduct the workup, and then send them for procedures. So we have that lag, and we must be aware of that where we stand today. And a point that I would like to make about the SENT trial as well, there are almost 22 patients that were excluded from those studies. They were potentially malignant disorders. So they were not even cancers. So their early diagnosis and community health services were picking up those and sending them for the biopsies. So when we are having a population where the trial patients itself have 22 patients, almost 20% of the patients as potentially malignant disorders, and we are comparing to a country where most of them are presenting at stage 3 and stage 4. Then we think about research and funding. Definitely we are for research. And in our country, the incidence of oral and pharyngeal cancers is equal to leukemia in the developed world. But the research funding for the leukemia is 20 times higher. The physician to patient ratio, we do not have to compare. We are well aware of that. So we understand that we are going to go for a simple surgery or a logistic heavy surgery. So we have to be very, very careful about the access and the affordability. Now let's once again brief what a sentinel node biopsy procedure is. So we identify a T1 or a T2 N0 patients. We perform an investigation of imaging the neck and rule out the metastasis. That costs around 8 to 10,000 rupees. Diagnosed as clinically N0, then perform a sentinel node biopsy with a 20,000 cost of the scintigraphy, the drugs, the surgery, around 60,000. I'm taking it at the minimal. A pathological cost of 20,000 and adding something for the step serial sectioning. If it comes out to be negative, we go for observation. So the observation alone costs around 1 to 2 lakh rupees. Now, if it comes out to be positive, either ITC or a micrometastasis or a macrometastasis, we do a surgery again. We do the pathology again. We add on another 2.7 lakhs on the cost. And then in that elective neck dissections with the surgery and the pathology, and another cost for the adjuvant as well of 1.5 lakh rupees. So what are we going towards? Are we really ready for that? Is it really cost effective? And these are some of the studies that analyze the cost effectiveness. A surgery in India is costing around head neck cancer surgeries around 80,000, and this is one of the government centers with certain rebates, as compared to around 48 lakh rupees in a developed country, or a pancreatic duodenal surgery for 3,50,000 rupees as compared to 1.1 CR in a developed world. Cost of frozen section is 15,000 in our country. And we are going to push those costs as we are going to increase the number of frozens as well. IHCs per sample as well. So what is the cost effectiveness of sentinel node biopsy? Now, even in the developed world, when we look at the geographical distribution of the usage, these are more or less centered around the developed oncological institutes, where they are practicing this labor intensive and research intensive, because they are towards research. They are trying to identify and they are trying to develop this technology of sentinel node biopsy. And once again, I am pro developing that technology, and it has still to develop. With these developed countries, they have just 1/3, 3/8, 2 units, 5 units across the entire country to perform a sentinel node biopsy. And I'm pretty sure in the next 10 years, they are going to be coming up with many more. But they still have to come up to that level, and we still are struggling for the preventive oncology. We have the CENT trial, which was conducted over 5 years in 14 centers. So there were just 7 patients per center per year. And they found an occult metastasis in 23% of the patients, 14% false negatives, and only 8 patients were salvageable. Now imagine you multiply these numbers by just 1,000. That is our situation right now with 12 lakhs patients per year. How many will we be able to salvage at the end of the year? Now we compare the recurrences as well. 23% were there in the CENT trial, 10.2% in the N0 trial, and just the CENT trial with the SNB negative, they were 14%. So still with the sentinel node biopsy, its recurrences are higher as compared to the elective neck dissection arm. Now, this was the American College of the Surgeons Oncology Group. They validated a study, they did the validation study, and what they found was that in floor of the mouth tumors, the false negative rate was as high as 25%. Now, we are performing a procedure. We have different subsites. We have buccal mucosa, we have oral cavity. Ours are more of buccal mucosa, buccoalveolar complex cancers, which we top. And if we are going to have that outcome, how are we going to compare with the tongue cancer? Definitely, we have a significant amount of tongue cancers, but we need to pick them early at the level of potentially malignant lesions to the conversion of squamous cell carcinoma or carcinoma in situ stages to perform the sentinel node biopsy, rather than the one that are actually presenting with a doubtful thickness, that we have to be very careful that we are not going beyond 5 millimeters or 6 millimeters, injecting the dye. And we have tumors which are already touching the midline. We talk about unexpected drainage. Now, that unexpected drainage is quite low, at as low as 2.9%. And definitely, that may be one of the indications of selecting patients to do a contralateral neck. But I am pretty sure that this also needs to be evaluated, and this indication also needs to be developed. We talk about the isolated tumor cells and the micrometastasis. Now, once again, everybody said that the literature needs to be developed, and we are working on it. The outcome for isolated tumor cells is almost equal to an N0 neck as compared to the micrometastasis and the macrometastasis. Even the CENT trial had 48% of the patients with micrometastasis. So in this one, again, the sentinel node identification is excellent. And I also say that, yes, sentinel node biopsy is definitely going to identify. You are going to inject a dye, get the sentinel nodes. We are doing that procedure to find out whether the node is positive or not. But the debate is not whether we are going to identify that the node or not. The debate is about, we are going to perform a procedure on the patients. We are going to see whether if we are removing it or leaving it as such, is it going to affect survival? And that is what we are going to study. So if we are not going to remove the entire neck nodes, and that is why in the N0 trial, when we had done the neck dissection in the N0 trial, all were clinically N0, but removal of those nodes, the fibrofatty tissue itself had improved survival. So we have to look at the biology. And again, all the trials that were done, they were showing the non-inferiority of sentinel node biopsy over a standard established elective neck dissection. They had not established a superiority. They are saying that, yes, we can be non-inferior, we can practice it. But with elective neck dissection having an 80% survival, we still have 20% things to understand for the biology to improve that survival. So we have to work in that direction as well. Can we do IHC and step serial sectioning routinely for our patients? Because if we can, we are going to identify those micrometastases in the selective neck dissection as well. And considering all the cost analysis and everything, it is not worth the effort right now. As I already told, the survival for micrometastasis to macrometastasis was significant. But comparing micrometastasis to a PN0, the survival, there is no different. So micrometastasis behaves like PN0, and let's treat them as PN0. Definitely, there will be no shoulder dysfunction if we are going to do a sentinel node biopsy. The scar is also going to be low, but if we have a single horizontal skin crease incision, which the surgeons are very comfortable with in performing a selective neck dissections, and now with the minimally invasive techniques for development of the neck, we can also avoid a neck scar altogether. So if we are talking about scar, we can also do a robotic or a retroauricular neck dissection. So the quality of life, this was very smartly presented, but all the studies, when they compared the quality of life in terms of shoulder dysfunction, most of them, they had, after 6 months, they have a similar outcome. Definitely the physiotherapy cost may go up, but we can do away with that as compared to the labor intensive pathologist cost, because the pathologist is going to cost more than a physiotherapist. So in this NCDB analysis, once again, they had a similar survival rates as compared to SLNB, and they had used it for the lip cancers and without any difference in the hazard ratio. So are we really ready for that? Definitely NCCN guidelines definitely tells us and advocates that we can use sentinel node biopsy, and we must use, but you must have that infrastructure to practice it. I borrowed this slide from you. So we understand the limitations, but a two-stage procedure, and the 10% is the numbers. If your population is 2 lakhs and you have 2,200 patients of cancers, 2 patients for a redo surgery is doable. But 2,000 patients for a redo surgery is not. So before we start, we have to look at the infrastructure. We have to develop the infrastructure. We have to understand that we have to train the manpower. We are here to develop the standardization of a sentinel node biopsy procedure right now. That itself is going to take some years. So definitely it will take some time. And in arrangements in high volume center, they need to be modulated, because if we are looking at 2,000 patients a year, 10% is a huge number. We have to expand our pathology services. We may have 3-4 buildings with the pathology itself. And surgeons are very comfortable in doing elective neck dissection. So that can altogether avoid a sentinel node biopsy and have a good survival once again. And yesterday itself, we had a case where we have to go in for the level 4 neck dissection for the sentinel node biopsy. Now going in after 5 days or after 10 days to do a neck dissection in those with the violated planes, it's going to be a cumbersome procedure once again. Once again, minimally invasive techniques are developing, and we must also focus on those as surgeons. So I would say sentinel node biopsy is still evolving molecular, because molecular tagging and the other dyes are also being worked upon. And maybe with the better understanding of the pathology, we will be able to identify the nodes which are true positive, right, without excising them. So we must focus more on early detection and awareness, which is going to get us more early patients where we can practice the sentinel node biopsy. Now, all these investigations, this is the computer, the first computer that was built. It appeared quite cumbersome, but it evolved to our pockets-friendly computers now. But the Graham Bell's phone, which was initially said what could be the use when every center cannot or every place cannot have it, and now we have in our pockets. Or this aeroplane which was developed. And Ferdinand Foch very well said that these are just toys for no military value. Similarly, sentinel node biopsy is developing tool. We have to develop that technique, and once they have developed perfectly, we are going to utilize it, just like we utilize the aeroplanes right now. So thank you, and I leave it up to you to decide whether we should use sentinel node biopsy or not.
Thank you, Richa and Aseem. Prathamesh, any final words? Prathamesh?
No, KK, I think they presented it very well.
Yeah.
My only question to both of them is, if we are going to move forward, I mean, we don't have a rebuttal, but my question to both of them is, if we have to go ahead, what would their guidelines for the common practitioner and the institutions? Both of them.
Yeah, Richa?
Sir, if we have to go ahead with it, I think even for the institution, we need to emphasize that it's the teamwork. So there has to be a valid protocol for the nuclear medicine, for the surgeons, and as well as for the pathologists. It's a complete sync. Any mistake anywhere is the false negative for this procedure and really can jeopardize the patient. And before we really start doing it, we should standardize it with adequate numbers so that all the teams are very well versed with it. And for the patient and for the people who are doing it in private, patient selection, of course, it's a must for the institution as well, but patient selection is very, very important. We need to select the right patient, T1, T2s who are clinico-radiologically node negative, and they can probably collaborate with their friends from the nuclear medicine and the pathologists, because it's a teamwork, and I think only then can it be done in private. But if they don't have the infrastructure or the perfect team to do it, I think elective neck dissection is a very safe procedure which can be done by majority, and we all know it how to do it well. So then it's better to go for elective neck dissection than a poorly done sentinel node biopsy.
Aseem?
So, sir, I definitely agree that we need to develop the technology and train the manpower, because what happens is we can get the technique, we can get the instruments, but training is the part that we have to standardize. And unless the standardization is there, a center may be performing it very well, but if there is no standardization, we will never be able to match the results. And that is why it is very important that we standardize them first and then only routinely advise it. Because even in the Garrel's trial, it was very well pointed out that whenever we have the surgeons who were experienced with the sentinel node biopsy, they have 100% identification rate as compared to those who are not trained, around 94%. So we have to be very, very prudent when we are advising this for common practice.
Yeah.